Thank you to the organizers for inviting me to talk to you today about what's new for TB treatment. So here's my disclosure, and here are the objectives for this presentation, which will touch on advances in TB treatment with a special emphasis on HIV co-infection. So I don't need to tell this audience that TB is still a huge global problem, but I thought a few numbers are worth touching on. So these are data from the WHO 2020 report. On the left is their target of 40 million people that need to be treated between 2018 and 22 to meet the global goal of TB elimination. And unfortunately, only 14 million were treated in the first 2 years. And similarly for preventive therapy, the goal of 30 million looks as if it's going to fall well short, as only 6 million received preventive therapy in 2018 and 19. And we suspect that these numbers will be even worse because of the COVID pandemic, although we don't have good data yet. The Global Fund estimate that approximately 1 million less people were treated for TB in 2020, even though there were not 1 million less people infected with TB needing treatment. So that's a problem. So to talk first about preventive therapy for TB, where we do have some advances, overall uptake of this strategy, even though it works well, is very poor. So this treatment cascades illustrate that of 100 people intended for screening, about 3/4 perhaps will be tested, about half referred if positive for TB infection, about a third given treatment, started actual therapy for their TB infection, and a little less than 20% actually completed, which is very sad. And the reasons are several. Mostly it's because providers and patients think that the current preventive therapy regimens are just too long. People don't want to take 6 to 9 months of medicine for a disease that they don't even really think they have. The drugs that we have available are not benign. You know, there are some serious side effects that can occur with all TB drugs. Providers worry about missing a case of active TB and giving someone monotherapy in that setting, breeding drug resistance. This has not been proven to happen in real life, but it's still a concern. And for patients with HIV, there has been a lot of emphasis on starting antiretroviral therapy and less so about offering TB preventive therapy, although that has improved somewhat of late. So this is a Cochrane review of very many clinical trials of patients with HIV who received INH preventive therapy for TB and what the results look like. So overall, reduction in TB was about 36%, which is not great, but it's still a definite positive finding. For those who had positive TB skin test, positive PPD, the reduction was much better at 60%. So this is clearly a highly effective intervention, although underutilized. But we have data from mouse models. This is data from the laboratory of Eric Nuremberger at Johns Hopkins in Baltimore, showing that a 4-week regimen of isoniazid with rifampicin, a different kind of rifamycin, is as good as 9 months of isoniazid, which is the standard preventive therapy. And so because in clinical trials of TB prevention, we don't have a good way to be able to diagnose infection in people or find the bacteria that infect them and see if we can make them go away. We have to jump straight from mouse work to a big phase 3 trial where people are given the preventive strategy and then followed to see who actually develops TB and who doesn't. So just briefly on this rifapentin, which is a different kind of rifamycin. These are the three that are available. Rifampicin, which is the standard therapy used for TB treatment and prevention on the left. Rifabutin, which is a drug which is not widely used globally. It's quite popular in the US because it has less drug-drug interactions. And rifapentin, which has these two pentyl rings, which you can see on the bottom right, and is a more potent drug against MTB. It has a longer half-life. It also has more drug interactions, but the side effects are similar. So this is a drug with there is several potential advantages for both TB treatment and prevention. And so based on the mouse data, a team of us proposed to the AIDS clinical trials group of the US NIH a study to look at this 4-month regimen of daily rifapentin with INH to compare it with the standard 9 months of daily isoniazid for prevention of TB in people who had HIV infection. And because the number of people who actually get TB is relatively small compared to those infected, we had to have a large study. So this required 3,000 participants. We enrolled adults and adolescents without active TB, and they were randomized to one arm or the other and then followed for 3 years. Here are the characteristics of the study participants, most of them in low and middle income countries, about 15% North America, about half and half men and women, median CD4 cell count 470. And after 3 months of follow-up, we were delighted to find that the incidence of TB in both arms, the 9 months of isoniazid and the 1 month of rifapentin with isoniazid, was exactly the same. So exactly the same number of people got TB in both arms, and this new ultra short course regimen met the non-inferiority margin that was designed for this trial. Adverse events were generally less in the 1 month regimen, and no surprises were seen. There were no hypersensitivity reactions, and a few patients with neutropenia, elevated liver enzymes, and a few with neuropathy. But overall, relatively small numbers when you consider there's about 1,500 patients in the 1 HP arm. And so you could make a case for using this regimen without needing to do any laboratory monitoring of participants. Treatment completion was the best we've ever seen in a clinical trial at 97%. Obviously, this was in the setting of a research study and will not be as good when it's rolled out into a real life setting, but still the best we've ever seen, and we were very pleased about that. We also did drug-drug interaction studies with this 1 month regimen and efavirenz on the left, and you can see there that there was really no change in efavirenz concentrations during this 1 month of therapy, so no dose adjustments, and they can be safely co-administered, although that is not the case for nevirapine, although that's a drug we use a lot less now, so not such a disadvantage. We don't have data yet on using this regimen with dolutegravir, but there is a study that will be examining that, and we hope to get some information about that in the very near future. So in summary, this ultra short course 1 month of daily rifapentin and isoniazid was non-inferior to the standard therapy in people with HIV infection. Easy to administer, safe and effective, can be used with efavirenz and with excellent treatment completion. So it is now being endorsed by the WHO as an alternate TB preventive therapy regimen. One of the issues, of course, with any rifamycin-based regimen is drug-drug interactions. And so this slide illustrates all of the different ways that drugs can interact, either by enzyme induction, transporters, or upregulation of gene expression. And rifamycins are basically the poster child for drug-drug interactions, in that they interact with all of the mechanisms available and make it quite difficult to co-administer them with many drugs, particularly antiretroviral agents. And so this table illustrates the currently available TB preventive therapy regimens on the left, whether or not they're recommended by the WHO, what age group, and then what compatible antiretroviral therapy you can use with them and the supporting evidence. So as you can see, for the 1 month regimen, we still lack data using it with dolutegravir or any other antiviral therapy to date. Those that want to look this up, the US Department of Health and Human Services have antiretroviral treatment guidelines with drug interaction tables that are updated regularly, and an excellent resource for looking at this. And the University of Liverpool in the UK has a very nice web-based application where you can also look up drug-drug interactions to help with this. And here's the WHO endorsement in their update to the consolidated guidelines for TB prevention in 2020. Interestingly, they did actually endorse this for patients with and without HIV infection, even though our study only looked at people with HIV infection. There's no reason to suggest it wouldn't work in people without. We just don't have clinical trial data to support that. And the CDC and the US Health and Human Services, we hope, will come along. So far, they've been a bit slow. So one of the issues, of course, with rollout of this regimen is access to rifampicin. Approval is still limited. It's not in every country. It's still quite a large number of pills. So patients have to take 5 pills a day. That's not including the vitamin B6 that you would want to give them along with it. It's quite a bit more expensive than daily isoniazid, but there are some generic manufacturers that are now making it. So we hope this becomes more widely available and cheaper as time goes forward. And even though the cost of the medicine is a bit more expensive, if you only have to take, of course, for 1 month and don't have to do any monitoring, that's a big cost saving. So turning now to treatment of actual TB disease. So as you all know, treatment of drug-susceptible TB disease has been standardized to 2 months of isoniazid, rifampin, pyrazinamide, and ethambutol, followed by 4 months of isoniazid with rifampicin. And this has been the case for about the last 40 years. This is not an easy regimen to take. The doses are quite large, even though there are many co-formulations, so it's not the number of pills that's large, it's just the daily doses. Side effects are common, and treatment completion rates are often suboptimal. Even those under directly observed therapy will default and not complete their treatment because people just get tired of it. If they're co-infected with HIV, there are limitations again on the antiretroviral regimens that can be co-administered, and there's a few listed here, but again, you might need to look these up on some website or table to make sure you're not going to experience a dangerous drug-drug interaction because of the rifampicin. So I'm pleased to report that after 40 years, we do finally have a 4-month regimen that is as good for curing drug-susceptible pulmonary tuberculosis. We've finally been able to make serious progress with this. And again, this was based on mouse data on the left, looking at, again, rifampicin, in this case, substituted for rifampicin, and with moxifloxacin substituted for ethambutol. In mice, this looks very good. And in a phase 2 study called Study 29X, also looked good there. And so a phase 3 study was developed and implemented called Study 31, or A5349, which was a large phase 3 trial and a collaboration between the US CDC, Centers for Disease Control and Prevention. They have a TB Trials Consortium, and also the AIDS Clinical Trials Group of the US NIH. And so the study was designed as a 3-arm study with the usual control arm at the top, and then 2 investigational arms, one with just high-dose rifampicin substituted for rifampicin, and the second with the same plus moxifloxacin substituted for ethambutol. Both of these were given for 17 weeks by directly observed therapy. You can see the doses listed on the bottom left. The non-inferiority margin for this trial was 6.6%, and the primary endpoint at 12 months after randomization. The study population were adults and adolescents with sputum or expert positive pulmonary TB. If HIV infected, initially we just enrolled those on efavirenz, and then later we enrolled those starting efavirenz. And the primary endpoint was TB-related, TB disease-free survival, at 12 months, as indicated by a cure. And patients were also assigned absence of cure, and a few were non-assessable. But most were assessable into cure or absence of cure, an unfavorable outcome. And at 12 months after randomization, as you can see here in the blue box, the regimen with rifampicin and moxifloxacin was within the 6% non-inferiority margin in all of the populations that were assigned for this trial. So this met the non-inferiority criteria in all analyses, although the regimen here with just the rifampicin substitution did not. And so the efficacy conclusions are that this regimen with moxifloxacin and rifampicin substitutions was non-inferior in all analyses, and results were consistent and robust. For the safety results, as you all know, TB drugs are not entirely benign. So as you can see here, quite a large proportion of study patients had a grade 3 to 5 adverse event, and quite a few also with treatment-related grade 3 to 5 adverse events, possibly more in the investigational arm with rifampicin and moxifloxacin, although tolerability was about the same, and very few patients died in any of the arms. The adverse events that we saw grade 3 or higher, there were no surprises here, mostly the kind of neutropenia and liver enzyme abnormalities that you see in patients taking TB treatment. We did worry about patients having QT prolongation because of the use of moxifloxacin over weeks and weeks, but happily that only occurred in 1 patient. There were 3 with cardiovascular endpoints, but only 1 was QT prolongation, so not a concern. There was also a subpopulation of patients co-infected with HIV, not a large population, but here are the demographics of the patients with and without HIV infection that more or less matched the general study population in terms of their comorbidities and demographics. And again, the efficacy results showed that patients with HIV infection also had results within the non-inferiority margin for rifampicin with moxifloxacin. And so this regimen worked just as well in patients with HIV infection, which was very good news to see. So the reason we did not have a lot of patients with HIV is because we had to enroll them in a staged fashion to make sure there were no dangerous or unacceptable drug interactions between efavirenz in this case and high-dose rifampicin. So initially we enrolled patients that were actually taking efavirenz-based antiviral therapy. And as you know, people with HIV who are on antiretroviral therapy have a much decreased risk of tuberculosis. So it took us a while to actually find enough patients to be able to do the PK analysis to see that it was safe to allow enrollment open to patients that were starting antiviral therapy, which is a much more common scenario when someone's diagnosed with TB and then they get diagnosed with HIV and start treatment afterwards. But for both settings, on the left, the concentrations, and on the right, the clearance of efavirenz, the patients were already on it, did not change significantly once TB treatment was started with high-dose rifampicin. And similarly, for those starting efavirenz, there was no significant interaction. So this regimen can be safely administered with high-dose rifampicin and efavirenz. We're hoping to get data from a clinical trial currently in development about use of this regimen with dolutegravir and other antiretroviral agents in the near future. So the conclusions for co-infected patients is that the 4-month rifampicin moxifloxacin regimen was non-inferior. We had no appreciable drug-drug interactions, and this regimen worked very well in co-infected patients too. So just briefly to talk on some new work and new directions with drug-resistant TB. After a really quite a long drought and a very slow trickle of TB drugs, the new TB drug pipeline is looking quite robust. And so many of those in early stages probably won't make it through to clinical development. But as you can see, there are quite a few in phase 1 and phase 2 trials. Rifampicin, moxi, we just talked about in the phase 3 trial, and then market approval in the US and other places for bedaquiline, delamanid, and protomanid, all new drugs with novel mechanisms of action and activity against drug-resistant TB, and a very welcome addition to the TB armamentarium. So in terms of drug resistance, there is some new definitions from WHO. I know definitions are a bit boring, but they are important, so we know exactly what we're talking about. Multi-drug resistant TB means TB that's resistant to rifamycin and isoniazid. If it's also resistant to a fluoroquinolone, it's known as pre-XDR or pre-extensively drug-resistant TB. And extensively drug-resistant TB is defined as resistance to rifamycins, isoniazid, fluoroquinolones, and at least one additional group A drug, which is what the WHO recommend for the treatment of drug-resistant TB, which I won't go into any great details for. But this is a very concerning and previously almost universally fatal illness, this XDR TB. But happily, we now have some data that I'll share in just a moment showing some progress in this area. So overall, treatment of MDR-TB is still really pretty awful. The standard is at least 5 drugs for months and months and months. People patients don't like it, providers don't like it. The evidence base is not great, and many of these drugs have not been rigorously tested in randomized clinical trials, and a lot of them are poorly tolerated. Just for example, daily injections of an aminoglycoside such as amikacin is really miserable for the patients and the providers and can cause, for example, hearing loss, which can be permanent and is really a horrible side effect. The WHO now endorsed the so-called Bangladesh regimen, which is an all-oral 9-month regimen that includes bedaquiline, one of these new drugs for drug-resistant TB, and so patients without fluoroquinolone resistance can take that, and a regimen of bedaquiline, that's the B, PA, which is protomanid, and linezolid for pre-XDR TB under operational research conditions. And this latter is based on the so-called NIXT-TB trial, which looked at this regimen of protomanid, bedaquiline, and linezolid for XDR TB, and was published last year in the New England Journal of Medicine. This was a relatively small study, but of the 109 participants, about half also had HIV, and the results were very dramatic. For a almost uniformly fatal disease, only 8 deaths was terrific. There were 2 relapses, but 66 patients in this study were cured, which was wonderful. But because these drugs are not easy to take, particularly long-term administration of linezolid, there was a fair amount of myelosuppression with anemia, neutropenia, and also peripheral neuropathy that participants experienced. And so the follow-on study, so-called XENIX, is looking at the same regimen but with less, smaller doses of linezolid to see if we can mitigate this toxicity from the linezolid. Here are the Kaplan-Meier curves of time to culture negative status amongst patients in the study, showing really no difference between MDR and XDR TB, and many patients achieving culture negative status just a few weeks after enrollment, which is fantastic. And so bedaquiline is now used in very many countries globally. Protominid and delaminid similarly getting rolled out, and improved access for use in treating patients with drug-resistant TB. We're looking at delaminid as a potential preventive for household contacts of those with drug-resistant TB. And the BPAL regimen is also being looked at for potential treatment shortening of drug-susceptible TB. So a lot of exciting developments in this area. And so in summary, progress in TB treatment is a little slow, but there have been some significant achievements in the last few years, particularly with ultra-short course preventive therapy, with the 1-month rifampicin and INH regimen. For the first time in 40 years, treatment shortening for drug-susceptible TB, a 4-month regimen that works very well using high-dose rifampicin and moxifloxacin substitution, and major improvements in treatment of drug-resistant TB with new drugs. But we still need, obviously, an effective vaccine would be wonderful. I'm sort of hoping that maybe all of this excitement over the COVID vaccines might spill over and somebody will develop as an mRNA vaccine for TB. We need better diagnostics. We're still stuck with sputum-based diagnostics and no good biomarkers for cure other than negative culture conversion, which is a fairly blunt instrument. So we need something a bit like a viral load that we use in HIV for TB, but we don't have that yet. Yet shorter regimens would be great. 4 months is good, but 3 months, 2 months, even 1 month would be even better. And sadly, as in so many other areas, studies for children are lagging behind. Dosing is not always well established. We don't have suitable pediatric formulations of all of the drugs, and pregnant women are excluded from very many trials, including all of the studies that I have reported to you today. So this needs to also be addressed. But overall, I think significant progress and optimism for the future. And with that, I'd just like to thank the organizers again for inviting me, and I look forward to the opportunity to answer questions. Thank you.